All right, so I'm going to talk to you about strain or spectral tracking echocardiography. I'm not sure how much of that will be, I guess, covered or used in your DDU exams, but Sam asked me to present this. Um, so uh, we know that the assessment of visual and global ventricular function has usually in the past really been relied on visual assessment. And since then, we've progressed, but the issue with visual assessment is it's so variable. It really depends on who looks at it, and they're like look at an eyeball and say, look, this is 50%, this is 45%. Um, and we know that the heart is a mechanical organ that really undergoes a cyclical deformation in both systole and diastole. And previously, um, looking at LV assessment, I mean, before uh, sonography became a real thing, they used to put beads into the myocardium during cardiac surgery, and using fluoroscopy, they used to be able to assess the movement of those beads to say, okay, what the overall function was. Since then, it moved on to tissue Doppler, and then we've now gone into Simpson's, EF or Simpson's biplane. Now, EF by Simpson's biplane is the one that is most widely used, and we use it on 4 and 2 chamber views. There are limitations, obviously, and it really assumes that the LV is a ellipsoid, and that's those geometric assumptions makes the EF assessment not that accurate. And again, there's also issues in terms of reproducibility because you really know, as particularly in ICU patients or any patients, that if you don't have the exact plane, then you're going to get a different measurement. And particularly if you foreshorten the LV, you're going to really either over or underestimate the EF. And again, it is load dependent. So high afterload will affect your ejection fraction. And that's one of the limitations of EF assessments of LV systolic function. The myocardial mechanics, the heart really is a twisting torsion, and it does this like kind of like clockwise and counterclockwise twisting both in systole and diastole, and that whichever way it untorques itself, it creates a suction mechanism, which really is what creates the blood flow into the LV. Now, there are fibers that go in either direction, in different direction, which I'll go into it in a moment. So strain, when we talk about strain, it is a dimensionless index. It looks at really the deformation of the tissues during systole and diastole. It is a measure of a change in length. In other words, from its original to its current position, and then you do a percentage change in that, and that will give you strain assessment or strain measurements. But the rate at which this changes is what is known as strain rate. Now, strain rate is not commonly used in clinical practice. It's usually more of a research practice, but we usually generally look at strain and then we assess it as a percentage. So when we look at myocardial deformation, it is really a phenomenon in a 3D aspect. You've got both longitudinal deformation, you've got circumferential deformation, and radial, in other words, the thickening and thinning of the myocardium. Now, the ejection fraction, when we do Simpson's biplane, doesn't account for this, but strained does. So the reason why it does this, it has all the different variation is, as I mentioned or alluded to it before, is that you've got these varying fibers. You've got these subendocardial fibers, which are in terms of going longitudinally. Then you've got these epicardial fibers, which are circumferential, and in between that, you've got these crisscrossing fibers, which kind of interlink the myocardium, and that overall gives this twisting torsion function. And when we look at that, we can assess the shortening both in terms of longitudinal, in terms of the way it elongates and shorten, and that's called longitudinal strain or global longitudinal strain, which we'll come to shortly. We can look at the twisting motion in a circumferential manner, and as well as the radial thickening and thinning of that, and we can look at that in terms of and do radial strain. Most of us will only come across longitudinal strain. And we'll look at the longitudinal shortening and lengthening of the myocardium and assess that or measure that clinically. Circumferential and radial strain is less so used clinically, more so for research purposes, but it has some benefits, particularly when you're looking at restrictive cardiomyopathy or infiltrative cardiomyopathy. So, like I said, strain is a measure of the force applied in terms of the change in deformation. And so when you look at that, when you look at strain, the way we calculate it or measure it essentially is by measuring what the over initial length that you started off with, and take it away from the current length, and then and then divide it by the overall length or the original length, and that will give you a strain change. Now, I've got this slide from one of Bonita Anderson's lectures back 10 years ago, and it is accessible online. Now, just looking at this, if you've got the original length as 5 centimeters and it elongates, or there's a longitudinal deformation of the myocardium or whatever the length, and it's now 8. 8 minus 5 divided by 5 gives you a lengthening of 60%. So that's the basic, mathematical, just calculations of strain. And the contrary is true as well. If there's shortening, in other words, you've got a myocardium that is 8 centimeters now shortens to 6 centimeters. You got 6 minus 8 divided by 8, you get a 25% reduction. Circumferential strain looks at the twisting motion of the myocardium, and at the base you've got a clockwise rotation. At the apex you've got a counterclockwise rotation, and that is what I was talking before, is the twisting motion of the myocardium and or of the LV, and that you can measure using circumferential strain. Radial strain, like I mentioned to you before, looks at the thickening and thinning of the myocardium. And again, we don't look at it as often in clinical practice, and for most of us, we would just be interested in the longitudinal strain in terms of the lengthening and shortening of the myocardium. Now, there is tissue Doppler strain, and that's an echo-based technique that measures between 2 points. And that is when strain essentially started off as becoming an issue. And it's probably about 10 years ago. And now really we don't really apply this technique anymore. And it looks at the velocities in terms of how far things have moved between 2 points, and we can measure that distance, and we can also measure that how long it took to change in that distance.
Just on that note, Shanthosh, hi on screen. For anyone that's seen the ASE boards, expect at least a few questions on this.
Right.
So there's some of them in the client textbook to work through, but I certainly got 3 or 4 questions based on TDI strain in my boards, and my understanding is it's quite a common thing to be asked on, as opposed to GLS. Certainly getting more questions about this.
Do you get asked it in your DDU exams?
I did not get asked in my DDU exams, but there have been asked. There's certainly been questions about GLS before in DDU exams.
Yeah, right.
Yeah.
Okay. I should ask them in terms of what the questions were before, but anyways. All right. So the way that the speckle tracking method works is that they look at the S2. So when you've got the ultrasound waves hitting the myocardium, and then when it hits a specific myocardium, it gives you this acoustic pattern. And it's essentially, the way I describe it is like a thumbprint in that section. And these are known as speckles. Now, what the computer or the AI essentially is able to do is it's able to track those speckles over time and distance or displacement from the original, and as a result can calculate, well, the velocity or change in velocity or change in displacement. Now, it is relatively angle independent. So unlike, where in tissue Doppler, you really need to have that alignment there, whereas strain, you don't really, well, speckle tracking strain, you don't really need that. And then overall, what you get this bullseye pattern or plot in the end, which I'll give you a couple of examples for, and you can have a look at that. And we can, it gives you this pattern. Now, what in more detail, this acoustic patterns or speckles the AI is able to identify these thumbprints and able to just see this motion in terms of changes. So what really happens is you get this region of interest. The software looks at this region and say, well, identifies by what's called block matching in terms of the pattern. And then it's able to track those motional changes based on those patterns and say, well, this is what the myocardium deformation is. And based on that, using what we've talked about in terms of how we calculate strain, we get this, GLS or global longitudinal strain. Now, when we look at the left ventricle, we talked about circumferential and radial strain, and that's usually obtained in the short axis at the papillary level. You can also look at it at the mitral and the apex, but generally, when you look at circumferential and radial, we make sure that we're at the papillary level and we measure that. Now, when we do longitudinal strain, we look at it 4, 2, and 3 chamber views. And you get, in each of those 4, 3, 2 chamber views, you get 6 segments. And it will highlight those 6 segments. And then we make sure that the timing is based on the aortic valve closure. And then what we get is the computer, it's fairly automated nowadays based on most of the packages. So you can just track it. And unfortunately, I think maybe later on in one of the sessions, we might be able to do, because I tried to do a hands-on session, but the patient's name kept coming up. So confidentiality, I can use that. So maybe once I'm more prepared, we can do a couple of examples on how to do strain. But I've got a paper that looks at how to do strain in more detail a bit later on. Yeah, I can, bring it hard. I think your strain would be just phenomenal, right? Like, but anyways, so when we look at strain and when we do the calculation, normally it's anything more than 18 and to minus 25. Remember, we're looking at minus digits or minus numbers, so the more negative, the better the strain. And the reason why is we're looking at the change in contraction. So remember, we started off with a bigger length and we went to a shorter length. So that contraction, so that negative value, that's why we get a negative value when we divide it over the initial, the longer distance. Does that make sense? People always get confused in terms of minus numbers and so forth. So generally anything minus 18 and to minus 25 is normal. So if you get a strain of minus 10, that is bad. Okay, so this is what we talked about, global longitudinal strain. We get it in your 3-chamber 4 and 2. And we measure, we using AI, we're using the software package, we can just track or trace around the myocardium or endocardium, and it will be able to give you that value. It will then come up with this quad form display plot, and this is quite important for a number of reasons. If you look at this region, this will kind of tell you if it's tracking well in terms of, so when you do the strain measurements either on your echo machines or post-processing on one of the vendors, whether it's GE or the Philips one or Tomtech or whichever one, you're able to see whether the strain, the region of interest is actually tracking the myocardium, because in some cases it may not be tracking, which you just have to align, we just have to readjust it. You'll also get a peak systolic strain for each of the 6 segments, and there you're able to tell, well, is it actually true reflection when it's actually tracking, or whether there's certain segments which are not, have reduced strain, and that may be due to either inherent diseases or infarct areas or sizes. And then you will get a what's called a strain curve. Now, if all of the curves are matching and I guess the trough is at aortic valve closure, then you know you've got a reasonable good strain curve or tracking. If for whatever reason one of them is off, in other words, one of the lines is off track, then you kind of know, hang on, this may not be tracking, or there's something actually wrong with it. You go back, reanalyze it to see whether it is tracking. If not, then it may be something that's a true reflection of the disease process. You get this bullseye pattern at the end. And it gives you a good code in terms of, well, if it's red, it's really shortening. If it's blue, then it's lengthening. And so you kind of can tell, well, is it, and the overall pattern gives you a clue as to what the underlying disease process is. Some of you guys may have heard this cherry on top pattern where you've got this, all of the red just in the apex, and everywhere else is kind of like pinkish blue, and that is typical of amyloid or AL amyloid. And so that pattern recognition will help you in terms of identifying what the underlying disease process is. There's also right ventricular strain. It's more more commonly used now as another marker or assessment of RV function in adjunct to your TAPC and RVS prime. In the past, we used to just use the left system, or the global longitudinal strain for the left ventricular strain on the RV, and just eliminating the septum and just looking at the RV free wall strain. But nowadays, most of the vendors have packages specific dedicated for RV strain, so you don't have to really do that. I'm not going to go into RV strain in any more detail, because I think it might be covered later on, but I doubt it will be covered in.
I think it's, for the sake of the GDU, it's probably it's still, I wouldn't say it's a research tool necessarily, but it's still not in everyday practice in another intensive care unit.
No, it's not. It's not in everyday practice. So I think it's something just to be aware of, because someone may come across and say, "Oh, RV strain or RV strain is normal," or whatnot, but it's definitely not used in clinical practice routinely at the moment. It may be. There's also LA strain, and LA strain is completely, I think it's another separate topic. And again, there is now packages for LA strain. And the reason why I mention LA strain now is before it used to be predominantly for research purposes, but now, particularly in the BSE guidelines that have been just released, like maybe a week or so ago, LA strain is used as a part of a kind of a referee to try and help you in terms of assessing diastolic dysfunction. And I think maybe sometime later on, someone might go through LA strain. And I think and since it's used in the BSE guidelines, I think it might be more commonly used.
It's going to be, isn't it?
It'd be something that'd be useful thing for us to look into down the track. It'd be next level. All right, clinical application of strain. When we look at strain or longitudinal, when I'm talking about strain, I'm predominantly looking at global longitudinal strain, or GLS. When we look at a strain, particularly in coronary artery disease, ischemic cardiomyopathy, it's useful. You can see certain segments where it's not as shortening, and it can give you kind of infarct pattern regions where certain areas of the RV or the inferior wall is not contracting at all. Therefore, it will kind of appear blue or less red, I guess, on the bullseye plot. And the strain would be reduced in that region, and you can, again, gives you another clue. It's like, hang on, there's something wrong in that region or in that pattern. But again, I'm not going to be using strain to tell me in terms of is there reduced, is this a inferior wall territory infarct, or is it an LAD infarct territory? It's when we talk about strain in non-ischemic cardiomyopathy, it's not really used overtly to diagnose non-ischemic cardiomyopathy. It's still based on your Simpson's biplane, but it is helpful in detecting subclinical disease or in early disease. And there are patients where I've said where the LVEF is normal and the GLS is reduced. And I said, hang on, this is not right. Nowadays, because of MRI, I'm able to send them for MRI and do a cardiac MRI, and the LV and the ejection fraction is reduced. And the MRI is much more accurate than the ejection fraction. And the question is, what do we do about it? We don't really know at the moment. At the moment, we monitor it. We may start them on anti-failure medications and really keep an eye on them before they really come back 5 or 10 years later with an EF of, say, 30 or 10%. So in that case, GLS is quite helpful to detect subclinical disease, more so than your Simpson's biplane.
So sorry, just on that last point you've got there, you talk about comparing to LVEF, right? And we classically think of LVEF as normal, mild, moderate, severe, based off maybe you go by 20% or 40% or whatever your cutoffs are for your guidelines you read. Is there any sort of stratification for a strain value that's getting increasingly closer to zero for you to say, okay, they've got mild impairment in strain, moderate impairment in strain, anything like that?
No, generally, if there's less than 18, so if they're coming with 17 or 16, we say that there's reduced strain or impaired global longitudinal strain.
Yeah.
I don't think there has been cutoffs in terms of -14 or -10 is more severe and more prognostically worse, but that also correlates with worse LVEF.
Yeah.
But no, generally not.
Yeah.
There is, yeah.
And much like someone's EF, you get an EF of, let's say it's 50%. You might go, oh, the error range in someone assessing that by Simpsons is maybe 5 or 10% either way. So measured as 50%, but in reality, it's probably fine off Simpsons. If someone has a GLS, it's just a bit high, right? It's -17 or 16.5. What are the chances of that being actually something that's significant versus being, oh, it's just a bit of measurement error and ignore it?
That is a fantastic question, and what I'm going to do is that after the clinical application, I'm going to go through some of the pitfalls or errors that can occur when we do strain measurements, because like I said, if the strain measurements done incorrectly, it will have the same problems as your Simpsons biplane. So if your images are foreshortened, or if you've not got an adequate tracking, you really need to look at other parameters to see, well, is your measurement actually correct or not? And that's why when you get that strain measurements, I look at, well, are the curves all aligned? And that will tell me whether it's tracking. Or is the overall plot, the bullseye plot, uniform?
Yeah.
And if not, then I'll be looking at the tracking and going back and then doing a reassessment.
Yeah.
So that's important. But then again, there's also going to be some variability between myself and yourself.
Yeah.
So if you do strain, and it's important that you do the strain for this next patient, for the same patient, particularly if you're going to do longitudinal assessments, because there are going to be some variations between you and me.
Yeah.
To get good at strain, they said there was a paper done, you need to have done at least 50 strain assessments before you're reasonably competent to say, well, to be good.
Yeah.
Anything less than that, you're going to be still a novice in terms of your analysis.
Yeah.
So there is a bit of a learning curve. Hypertrophic cardiomyopathy. We know that HCM is based on really scattered regions of fibers. They're all in disarray, and you've got segments of hypertrophic areas or thickened myocardium. And we know that when we look at EF, sometimes the EF doesn't reflect the overall function. The myocardium is really thickened. It's still normal, but you can kind of see it's not really squeezing or contracting as well as you'd like. But when you do your GLS, you can actually see that there is a reduction, and a cutoff of less than 15 was shown to be a independent indicator of adverse cardiac events in HCM. Now, chemotherapy-related cardiotoxicity, I think this is where strain is used mostly, particularly in clinical cardiology or particularly in the outpatient setting, because it has a significant impact on the patients. So what used to happen before is you give a lot of the anthracyclines or cardiotoxic agents for chemotherapy. They did their ejection fraction, and then what would happen is 3 or 6 months later, they did the ejection fraction again. It was fine, and then another 3 or 6 months later, ejection fraction is 30%. It's really reduced. The problem, as I said, with EF is that it's a Simpsons biplane, it's a gross measurement. It doesn't detect subclinical dysfunction, and by the time that the ejection fraction is low, it's probably too late for us to intervene or do something about it. So with strain, you can kind of detect some subtle variations. So what generally happens is you follow them up, and they've come in for their clinic echo before they do their chemotherapy. The GLS is about 18 or 20. 3 months later or 6 months later, you do another GLS, and it's now 17 or 16. the EF is still normal, and usually it is still normal at that point. What we do in that case is, because there's some subclinical dysfunction, we kind of start them on a antifailure medication, either a ACE or beta blocker, and really monitor them closely. And this really helps us prolong the chemotherapy, but also act more aggressively if things start to go pear-shaped sooner, before the ejection fraction goes well below. Because what happens is, if the EF goes well below what they're supposed to have, then they'll come off the chemotherapies, and then it'll just be bad news for the patient all around. So I think chemotherapy-related cardiotoxicity, it has a significant impact.
And that 10 to 15%, that's a reduction in what their original value was. So if they're originally minus 20, and then they go down to, say, minus 18, that's a reduction of 10% of their minus 20.
That's enough for us to say something.
Yeah.
Something
even though your new value may still fall within normal limits, right?
Yeah, 100%.
Yeah.
And again, this is also very important that you do the strain is done correctly and whatnot. And usually, if there's oncology clinics where the sonographers just do strain day in and day out, and they're really good at what they do, and that's where high volume centers are really important.
Yeah, cardio-oncologist, right?
All right, so valvular heart disease. There has been research done in terms of whether strain can help us predict subclinical dysfunction, and therefore send them off to surgery sooner. And again, at the moment, it has not translated into clinical practice because as I mentioned before, a reduction in LVF indicates impairment of contractility, and often that's too late for us to say, okay, well, to reverse anything after surgery. So then they're like, well, can we do something with strain? And really, at the moment, the answer is not really. Some people kind of do use it as a marker and say, look, there is a bit of dysfunction, but most of the time, if there's valvular heart disease, they rely on LV ejection fraction to determine whether this patient would benefit from surgery or not. Cardiac amyloid. Again, the strain has been quite useful in terms of identifying whether there's some sort of abnormalities. So what generally happens with infiltrative cardiomyopathy, particularly in terms of cardiac amyloid, you get this misfolded fibrillar proteins in the myocardium, which kind of restrict the contraction of the heart. And in AL amyloid, what you generally tend to get is you get this infiltration of these misfolded proteins everywhere else, but usually the apex is spared. It's not completely spared. There's still some misfolded proteins there, but it's less so. Now, someone's going to ask me why that's the case, and I've asked all the experts, and no one's been able to tell me why that's the case, or why there is sparing of the apex but not anywhere else. So this gives us a good clue. So what we do when we do GLS, or global longitudinal strain, and we get a bullseye pattern, and we can see the apex is spared and everywhere else it's not spared, we kind of know, hang on, this person has AL amyloid or cardiac amyloidosis. What this then allows us to do is we can send them off to treatment, or get further investigations, do a PET scan or a bone scan, and really identify them and get them treatment earlier. Nowadays, there is treatment, particularly for wild type and AL amyloid. So it's quite important to assess that or measure that. Practical guidance. So there's a great paper by Prof. Nagishi and so forth in terms of how to actually do strain measurements. And I'll go through, and there's like essentially 7 steps, and I'll go through most of them just step by step. So most importantly, it's getting the adequate image, or good image quality, right? So on the left, the A panel, you've got good endocardial border definition, and that's quite critical in terms of when you want to have good tracking, and that's considered good for strain. In your B segment, the apex is not really well visualized and a bit shortened, or there's a bit of artifact there. And so the AI or the strain is really going to have trouble in terms of tracking that segment. So, and therefore you should, if you're going to do strain, you should exclude those 2 segments. And there's ways to do that when you actually do that. The problem is a lot of the patients in ICU, the images are going to look like this, right, on the panel C, and it's going to be really terrible for strain tracking, and that's actually reflected in most of our studies where we have trouble tracking, and that's just the nature of the beast. So when the endocardial border is not really visible throughout the entire cardiac cycle, then strain is not possible. And if you can't get good image quality, there's no point doing strain because you're going to get a dodgy result. Then you're going to say, well, if you get, what's the saying? Shit in,
Rubbish in, rubbish out.
Yeah, rubbish in, rubbish out.
Just out of interest, like, just looking at the rhythm strips there, right? Like, there's some of these patients have broad, complex rhythms and presumably bundle branch blocks. Does a dysrhythmia, like a conduction delay, for example, does that interfere with strain?
Yeah, 100%. And that it will actually tell you with the strain curve, because what happens with the conduction delays or conduction defects, or if they've got a left bundle branch block, what happens is it lengthens when all the other all the segments contracts, and you can see this where there's certain segments where it just flops out. It kind of like it lengthens, and you get this, like on the curve, you'll see that segment move out compared to all the other segments.
Presumably move out,
and then move back in.
Yeah,
so there is a delay. So
yeah. Okay.
So it's important to also identify that there is a conduction defect. And when you look at the strain and do the strain pattern, you can kind of make an assessment and say, well, there is a defect, most likely in the context of a bundle branch blocks, and so that will kind of help you make that call. Location or region of interest. So when we do this strain or speckle tracking, so what I do some dots around the LV. It's important that the region of interest, or the ROI, tracks exactly the myocardium or the endocardium that you really want. The problem with the one on the left panel, or panel A, is that you've got some of the pericardium, which is also included. So it's where's my mouse? Can you guys see that where my mouse is? It's also included there, and that's reflected in this strain curve, where you can see that it really isn't following that peak. As soon as you fix that region of interest and you kind of just pull it in, it kind of gets better, but it's not really like it hasn't really come all aligned. So then again, what I would do is I would go back, remeasure it, and really make sure that I get a better assessment or region of interest. But making sure that you don't include the pericardium, because otherwise you're going to get an incorrect strain assessment. It's also important that we don't include the PAP muscle, because if you include the PAP muscle, it's going to give you a kind of exaggerated strain. And as you can see, where in this case, where they've included the PAP muscle, your strain is -20. Happy days, go home. Like, and patient's normal. But really, if you exclude the PAP muscle, the strain is reduced. It's -13.5. So that's one of the pitfalls commonly that we see, that people include the PAP muscles, but you just want the endocardium, just similar to when you do your EF biplanes. Mitral annulus. When we do your strain analysis again, in this case, what they've done is they've gone too far deep into including the mitral annulus, and actually they've gone into the left atrium. And what happens is you can see that where it's not contracting as well, and you get this segment where it's kind of lengthening or not as well. And as soon as you've corrected this defect and you kind of pull it in so that it's just anchoring rather than going deep into the LA, you get a much better result. So those are these areas that you need to go back and just have a look or assess when you do your strain measurements, or that you don't go too far deep into the atrium and just stop at the annulus. Otherwise, your strain curve will tell you, or the bullseye plot will also tell you that there is some issue, and then you just go back, readjust it, and then you get a much more better reflection of what your strain is supposed to be. In this case, similar, when you do your 3-chamber strain analysis or strain tracing, in this case, what they've done is they've gone way too deep into the anterior septum and almost into your LVOT outflow tract. And this is going to really exaggerate again the septal bulge, and it's going to give an exaggerated result. you really want to pull that back in so that it's not too deep into the LVO and just LVOT. And really, you just want to make sure that you don't include that and just include the endocardium of the LV. And that again will give you a much better reflection. And you can see that subtle difference. You went from 14.6 to 19.3, so really abnormal to just normal, right? And so those things are quite important just to make sure that you're aware of that and just adjust it accordingly. It's also important that with the region of interest, we can really we can change the thickness to really thin or to really thick. And it's important that we just make sure that it's the endocardium is adequately included, and that you don't really make it too thick, because if you make it too thick, you're going to get parts of the pericardium, and then you're going to get an incorrect result. And again, that difference, a really thick where we included the pericardium, you went from an abnormal to just maybe just mildly abnormal to minus 17.5. And then the opposite is true if you've got a really thin thing where you're not accurately reflecting the strain curve or the tracking of the endocardium, you're going to get the opposite where you've went from a normal to really it should have been minus 15.9 or a bit less or mild. So making sure that your endocardium or your region of interest is not too thick or too thin and just adequately reflects is important, because that will also affect the way you measure that. And the reason why I'm mentioning all of this is because knowing what the pitfalls are or the errors can be, you can go back and say, okay, hang on, where did I stuff up in terms of my analysis or whatnot? Or is it, or if someone else has done it and you just want to kind of just double check and say, hang on, yeah, they've done it correctly. That's a good reflection. And this is like, your papillary muscles, making sure that you've excluded that or mimics, so that you're aware that you're actually tracking the LV, not just something else. Lastly, we'll just go through a couple of examples of bullseye plot, and I've mentioned to you some of it. The first one is reasonably easy because I've kind of mentioned it before. Anyone want to describe that pattern? Panel A.
Yeah, Shanthosh, I'm Niall Kennedy.
Hi.
It looks like from a point of view of the global longitudinal strain that your apex is preserved. So strain is reduced pretty much everywhere, but apex preserved, which would, and looking at the 2D images, perhaps point you towards a suspicion for cardiac amyloidosis.
Yeah, 100%. Yeah, this is your classical, cherry on top pattern, where your apex is preserved, and this is in keeping with cardiac amyloid. So if you see this, you really have to question and say, and it's quite specific, to be honest. So I would really question whether this patient has cardiac amyloid and then go back and so forth. Just as a side note, if you had the opposite where it was all blue on top and kind of pink everywhere else, so it's known as a blueberry on top, has anyone come across that term?
No.
Why would you get blue on top? In other words, kind of lengthening.
Maybe apical aneurysm or something.
Yeah, exactly
or,
right. Or, what's another example of apical aneurysm? What was that, Rishi?
Hypertrophic cardiomyopathy, apical variant.
Not so much hypertrophic cardiomyopathy, but this is where you've got some, the apex is kind of aneurysmal or lengthening.
Takotsubo or something.
Yeah, Takotsubo's. Yeah.
Yeah. Cool. Yeah.
Okay. So that's if you do strain on a Takotsubo, you should get a blueberry on top as opposed to the cherry on top. The next one. This one's kind of hard because it's like you've got your strain is relatively preserved. You've got some reduction in strain assessment in your, in the anterior septum and septal regions. Looking at the 2D still images, looks a bit thickened.
Is it kind of a hypertension kind of disease?
Yeah, it could be hypertensive disease. Yeah, 100%. I would agree. It could also be, you know, hypertrophic cardiomyopathy. So it's one of those things that you will see where the septum is really bulging or hypertrophic. Like you will get this pattern where the strain is reduced in that segment. Panel C.
Kind of similar to what you talked about with the blueberry on top, but
Kind of similar, yeah.
And the ace shaped heart chamber, I think.
Yes. What is that?
Hypertrophic cardiomyopathy apical variant.
Yeah, this is a hypertrophic cardiomyopathy, but what kind of variant?
Is it apical?
Yeah, apical.
Apical.
Apical HCM. So you get this common, like in that where the strain is reduced in the apex, but reasonably okay everywhere else. And you can kind of it's pretty hard. It's not fair, to be honest, but you get this apex where it's a bit more hypertrophied compared to everywhere else, not everybody else. And the last one. Kind of similar to the one previously.
It's a mid-ventricular cavity obstruction kind of thing.
This is kind of got what we talked about before. You get a bit of blue in there. You know, you've got this apex. It could be, I think it is aneurysmal in that segment. So this is in keeping with where you've got an apical infarct or LAD or mid LAD infarct. Speaking of infarct, what territory is this?
RCA.
Yeah, right. So you've got your posterior inferior hyperkinesis, or where the strain is quite reduced. So this is the in keeping with an RCA infarct. So if you do strain on patterns like this, it's in keeping with like a right coronary artery. I think that's it so far. So it's just a quick run through strain. I think the most important is just have a read of that paper in terms of how to do strain. Down the track, if you guys want, we can happy to do some cases where we do some actual live examples, and maybe Ben's gone, where I can do strain on actual Ben or someone else. Michael Pittard, you can volunteer.
I'd be very interested.
And we could do strain analysis. In fact, we should get Ben to do a marathon and do a pre and post strain and see what that is. But yeah, or even Sam. I'm sure I can get Sam to do do a marathon and do strain before and after. But if you guys want, we can do that and just do the practical aspects and how we actually do strain on while we do the actual measurements and what the implications are. So essentially, in summary, normal GLS, when we talk about global longitudinal strain, we're talking about -18, -19, -20 and above, or I guess that's negative. That is normal. Anything less will show you some subclinical dysfunction. It's important to kind of look at your strain curves and your strain overall. If I go back, bullseye curve, but also in terms of your map, that will kind of give you a clue as to if you've made an error in terms of whether it is actually tracking. And that, based on that, if you're not confident that it is tracking, go back, do the remeasure the strain and see if you can get a better result, and make sure you haven't done any of those pitfalls that we talked about in terms of overextending into the LA or included the papillary muscle or the pericardium, and that it's actually tracking. If you've done that, then you can be reasonably reassured that you've done the strain analysis reasonably well. What I haven't talked about is some of the downfalls or pitfalls of strain. It is still, even though LVEF or LV ejection fraction has its pitfalls in terms of it's load dependent, GLS is also relatively load dependent. So a higher afterload will give you a reduced strain. So that is one of those pitfalls. The other thing is if you've got terrible images, you're going to have a terrible time in terms of getting a good tracking of the endocardium and therefore good global longitudinal strain. So that is one of the other limitations. Then the third thing is, well, particularly in intensive care, when you've got a -15 GLS, so it's impaired global longitudinal strain, but the ejection fraction is normal, we don't really know what to do with that. We don't even know what that means. So at the moment, the application is still difficult in terms of just subtle dysfunction or subclinical dysfunction, particularly in intensive care or critical care. What do you do about it? So its application is still, I guess, limited from that point of view. So those are some of the limitations of strain, and definitely in terms of the application. But I hope that kind of helps, because it's important. GLS will become, I guess, more so commonly used adjunct to EF in terms of assessing your LV. There's now, I mean, people have now moved on to myocardial work. That's a whole different ball game, but it's also based on strain. So you may come across that term, but it's definitely not in clinical application at the moment. Makes sense so far? Any questions?
No, thank you very much.
Shanthosh, obviously it's so dependent on the imaging quality, and I know you've been doing lots of echoes in ICU the last 12 plus months. How often are you actually able to get images that are good enough that you can do strain that you think is actually accurate? I'm not asking for an exact number, but like.
No, so about 10 to 15% of Sam did a paper on this. He had 10 to 15%. I've got something similar in terms of getting a really good strain curve and assessment. And this is with me really trying hard. It's just because of their ventilation and their position. Strain assessment in the ICU is difficult.
Okay, thank you.
Shanthosh, that was great, thanks. I wanted to ask you about whether there's been any work done in septic cardiomyopathy, but I guess given the limitations of examinations in intensive care or critically ill patients, I guess that will be somewhat lacking as well.
Yeah, it's a good question. It's my project on this, so which I'm looking into GLS in septic population or septic cardiomyopathy. So when we talk about septic cardiomyopathy, a lot of the papers have based their definition or assessment on Simpson's biplane or EF, and they've also looked at RV dysfunction. GLS has been talked about, but the problem is not everyone has been using the same terminology in terms of GLS. Some have just said -17 as abnormal and -13 as abnormal. So not everyone's talking about apples and apples. But I think GLS will be impaired in septic cardiomyopathy. I've got the data, but I haven't analyzed it. So and I'm curious to see what it is. So ask me again in 6 months, and I'll be able to give you a better answer.
Great, thanks so much.
Anybody else?
Thanks, Shanthosh.
No worries. Cool. Thank you, guys. Have a good day. Good afternoon.
Thank you.
Thank you.
See you guys.